All right. Okay, fine. Thank you everyone for joining. This is our first fireside chat for the new year. So happy new year to everybody that's joined in. Today is our fireside chat number 188. And we have Professor Hany Hafez, who will be taking us through how to delay progression of chronic kidney disease. But before he starts, just a brief introduction about Prof. He's an Emeritus Professor of Nephrology and Medicine at Cairo University, but also the past President of ESNT. He is currently, and it's an honor to have the President of the African Society of Nephrology with us, and starting off the new year with a bang. He's also the Secretary General of the Middle East Society of Nephrology, a Councillor at the Declaration of Istanbul Custodian Group, and he's also the Chief of Nephrology Council, Arab Board, and Egyptian Fellowship. I had the honor of meeting Prof last year at the Kenya Renal Association. It was a pleasure to meet him, and we had shared some insights. So, Prof, you're more than welcome to take the floor and go ahead with your presentation. Thank you.
Thank you very much, Dr. Mazhar, for this kind introduction. And it is a great honor and privilege for me to be present with you in the first meeting of 2025. Happy New Year for all of you. And I hope this year will bring prosperity, health for Africa and for all of you. Today, I will be speaking about something very important, I think, especially for our continent, because we want to delay the progression of chronic kidney disease in view of deficiency of enough dialysis facilities for everybody, and still enough transplantation facilities. As we know, there are only 15 countries out of the 54 countries of Africa who are practicing transplantation now. So it's very important to try to delay the progression and try to, as long as possible, try to have our patients in the early stages of CKD rather than the late stages of CKD needing renal replacement. I will start by telling you that in 1990, the global incidence of CKD was 11.3 million, and the prevalence 147 million. It increased in 2016 to 21.3 million incidence and 275.9 million prevalence. And it is in 216, it is the number 16 leading cause of premature deaths worldwide. But this will be, after 15 years from now, in 2040, the fifth leading cause of premature deaths worldwide. So different from other diseases, it is increasing, not decreasing. We will try in this agenda to see what are the current management to reduce progression and what are the future management to reduce progression. This is actually my agenda in short. I will start by the current management, which have some evidence. Some of them have very good evidence in delaying the progression, like the blood pressure control and the RAS system blockade. Some have moderate incidence evidence, like uric acid lowering, alkali therapy, physical exercise, protein restriction, salt restriction, and smoking cessation. And others have some evidence, but insufficient till now: anemia control, statin, weight loss, and high fluid intake. Let's start with those with good evidence. I will start by the blood pressure control. And when you look to the map of the world in the right, you see that our African continent is one of the most prevalent regarding hypertension, with prevalence which is much higher than other continents. In black blue here, in dark blue, you see more than 30%, and in lighter blue, 25 to 30%. this is much less than, for example, United States or other areas in the world. This high prevalence of hypertension could be, of course, attributed to many causes, including the high salt intake in our continent, the APOL1 genetic factors, and other factors which lead to more prevalence of hypertension. This hypertension, unfortunately, is not very well controlled, because if we look to the SPRINT trial and the Joint National Committee goals of adjusting the blood pressure, we find that many of our patients are not in the target. The target should be, if the patient has heavy proteinuria, it should be 130 to 80 or even less in diabetic patients. And if the patient has less proteinuria, we can go up to 140, 90 in non-diabetic, and in diabetic it is even less, 130 over 40. And I think this is not fulfilled. I will give the example of Egypt, in which we find that not more than 30% of those who are hypertensive are well controlled. And even in the United States, figures less than 50% of hypertensive patients are in adequate control. What about the RAS blockade? We have old evidences since long time by the RENAL study and the IDNT study that ACE and ARBs reduced the doubling of serum creatinine and the end-stage renal disease. And even in diabetic and in non-diabetic cases, we have the studies of RAIN and the ASK and Benazapril studies. We know that these agents are very efficient in controlling not only the blood pressure, but also the proteinuria. This is the old evidence. But recently, in the recent years, we got even more data from the STOP ACE trial that was basically from the United Kingdom, and encouraged us to continue giving the RAS, not to discontinue it, even if the GFR declines a bit, because many of us were afraid from continuing this because of the rise of the creatinine and the deterioration. But this study, which followed the patients for long periods, concluded that continuing the RAS inhibitor would be beneficial. And this is the first evidence to control the blood pressure and to use RAS and blockers until later time. What about the moderate evidences in delaying the progression? I will start by the dietary salt restriction. Actually, there is no evidence that dietary salt restriction directly delays the progression, but we know very well that we cannot get a good blood pressure with high salt intake. So it is important to control the blood pressure. And also RAS blockade, many of the RAS inhibitors will not work if the patient is taking much salt in his diet. What about smoking? We have here a very nice study coming from China showing that cotinine, which is a primary metabolite of nicotine in the human body, present in the blood and widely used marker of tobacco exposure due to its long half-life, even 3-4 days after the smoking. And they found that this cotinine has a negative correlation with the GFR. So we can conclude that as smoking quantity increases, smoking leads to a decrease in the renal function. Because before this study, it was just a speculation that smoking is injurious, for example, for the cardiac status, for the lungs, but there was no strong evidence regarding the GFR and the kidney. And here, this association between smoking and renal function in people over 20 years old is present in this Chinese data. What about uric acid reduction? Uric acid reduction actually also is very debatable, because we have some studies. We have 8 randomized studies of allopurinol, 3 trials of them say that progression of renal failure is delayed by controlling the uric acid, and 5 trials showed no effect. One of them is the peerless study that I think I put the slide in the here about the peerless study, preventing early renal loss in diabetes in the peerless study. This was a multi-center clinical trial of allopurinol to prevent kidney function loss in type 1 diabetes, and the data were not very conclusive in the direction of controlling the uric acid will delay the progression. But definitely, when we have very high level of uric acid, it is worth treatment. But when it is borderline, for example, a uric acid of 7.5 or something, we may consider it as a secondary factor of the renal disease, and it is not very important to add allopurinol or fenofibrate. This is the peerless study. What about alkali therapy? There is growing evidence that giving bicarbonate or trying to reduce the acidosis of renal failure is important. And the rationale for this is that this will lead to more interstitial fibrosis, as you see in this schema, by different mechanisms. Acidemia will lead to RAS activation. Acidemia will lead to more production of renal ammonia, more complement activation, and acidemia will lead to endothelin receptor A and B stimulation, and this will end in interstitial fibrosis ultimately. We have here 4 long-term studies with follow-up of 1 to 5 years on 295 patients, showing that giving serum bicarbonate will lead to some improvement in the GFR. And these randomized studies, one is coming from the United States, another one on diabetics patient aged more than 18 years, and another one is coming from the UK in CKD 4-5 stages in patient more than 65 years. And the conclusion is again favoring alkali therapy in our patient. And I think nowadays giving some alkalization and keeping the serum bicarbonate in the range of 21 to 22 is one of the important lines of conservative treatment of chronic kidney disease. What about physical exercise? We know that physical exercise is associated with lower rate of decline function. Since 2009, we got this study, but later on, there are more studies about in the CJSON in 2014, showing that each 60-minute increase in the exercise, each 1 hour increase in the exercise will slow the GFR by 0.5% per year, which is very, very, very nice if we invite our patient to do physical exercise. Even walking, even doing any type of activity will slow the GFR decline and improve the virility, which is one of the problems of our patient, by improving the muscle activity. What about giving keto acids or amino acid analogues? There have been in the DOCI and even in the KDIGO also some recommendation that if we put the patient on very low protein diet, it could be reasonable to prescribe under close clinical supervision a dietary protein intake of 0.6 to 0.8 per day, and to give with it some of these supplements in the form of keto acids or amino acids, especially in very low protein intake. What about the fasting? Is fasting beneficial to our patient? This has been a plenary presented in the last ERA EDITA in Sweden, 2024, that fasting and decreasing the calories from around 1,400 to 800 may be beneficial in prolongation of these rats' life, even, and the kidney life. And the mechanism underlying this was a sort of affection of the tubulonephrosis and anisokaryosis, which decrease. And this is dietary restriction on the aging in DNA repair models led to better survival in these rats. So we can speculate that decreasing the calorie intake or fasting may be beneficial in our patient. This gives us an idea about the ideal body weight of our patients. Should be our patient will be very thin or very obese. And here we have a U-shaped curve. If the BMI is less than 25, the mortality increase. And if the BMI is more than 35, again, the mortality increase. This study has been done in around 500,000 of US veterans and showed that the best is to keep the BMI between 25 and 35, and this will be the best regarding the chronic kidney disease patients. What is the right amount of fluid to drink if you have chronic kidney disease? The USA is formed by the concept of 8 by 8. Drinking 8 glasses of water each day is beneficial. But again, we have some multiple debates about that. We have the USA Total Water Intake Study, the Australia Nutrition Questionnaire, and the Canada study in which keeping the urine volume is around 3 liters per day. The rate of GFR reduction was not actually associated with the fluid intake, but again, we should not put our patient on the dehydration side, especially in the hot weather of Africa. It is very wise to keep our patient well hydrated, but it's not very important to give much water. What about, and this is another evidence that chronic kidney disease of unknown etiology could be present in some parts of the world, including Egypt, Africa, Mexico, India, and Sri Lanka, in which one of the important underlying factor is the hot weather, in addition, of course, to other factors, including the use of agrochemicals, pesticides, heavy metals, some infection like hantavirus and leptospirosis, and again, some herbal medicine which are still present in our area. By this, I finished the first part of my talk, which is what is the current management to reduce the progression. And to recapitulate them again, we see that blood pressure control and RAS blockade have good evidence. Uric acid lowering, alkali, physical exercise, protein restriction, salt restriction, and smoking cessation have moderate evidence. And anemia correction, statins, weight loss, and high fluid intake have debatable evidence, insufficient evidence. And again, now let's proceed to the second part of my talk, which is what are the future management to reduce progression. And here I will borrow the pillars of the cardiologist who are telling that we have 4 pillars in the management. They are using, and I will say also now nephrologists have new pillars in the management of chronic kidney disease. The first of them will be the Flozin or the sodium glucose transporters. The second will be the GLP-1. The third will be the aldosterone antagonist, specifically finerenone. The fourth could be bardoxolone or gene-directed therapy, and we will come to this after that. Let's start with the Flozins. Now, there is a wave all over the world of using SGL2, and I know that tomorrow there will be one big, from AFRAN, one big Zoom about the use of SGL2 inhibitor. It is not only for nephrologists, it is also for diabetologists and for cardiologists. And even now, like it was one of the says telling, take an apple a day to keep the doctors away. They are telling now, take a Flozin a day will keep the doctors away. So we have many trials about these Flozins. Some of them are still ongoing, like this SCORED trial of some new Flozins like the sotagliflozin and kidney and cardiorenal outcome in its, and some of them are that you know them very well. The evidence, the first reported at the ESN about the use of frozen was on 2015. And now, after 10 years since the first report, it has got many popularity. In the first report, we were afraid from many side effects, including at the time a sort of gangrene, a sort of amputations, many side effects, increase of the urinary tract infection to a level that is uncontrollable. But with more evidence now, everybody is using these drugs with less complication. Now, this is the effect of some of the SGL2. This is, as you see, the nephroprotective effect of SGL2 inhibitor has been present in this meta-analysis of 13 randomized controlled trial, showing that the CKD progression will decrease by 0.63, as you see, and the AKI also will decrease. And the most famous of these are the DAPA CKD and the IMPA studies. All of them led to the KDIGO recommending the SGL2 inhibitor therapy as a part of a comprehensive treatment plan for most patients with CKD and type 2 diabetes mellitus. It got an FDA approval, and this FDA approval has been very, this FDA approval led to more popularity of these drugs. You see here, for example, in patients with type 2 diabetes, there is 36% reduction of the progression when in patients with type 2 diabetes, and without type 2 diabetes, 50% relative risk reduction, which is very significant and led to many society to include these drugs among their armamentarium of therapy. What about the IMPA kidney? Also a very important trial published in the New England Journal of Medicine, and showing again that these drugs will be very important in delaying the progression of chronic kidney disease, whether the patient has diabetes or not. The exclusion criteria in this study were the polycystic kidney disease and the kidney transplant recipients. And there was again a very good primary and secondary outcomes reached. The second pillar in the management, in the new management, is the GLP-1 receptor agonist, dulaglutide, for example, in this award trial, showing it associated with improvement in the deterioration of chronic kidney disease. And the FLOW study that has again been published in the ERA Edita and discussed in depth. This study was a multinational randomized controlled clinical trial involving many patients, more than 3,533 patients, divided into those who take the semaglutide 1 milligram plus the standard of care once weekly, versus those who are taking placebo and standard of care. And there is early trial cessation was recommended at the pre-specified interim analysis for efficacy, because there was superiority in the arm in which the semaglutide was present. The patients included in this study, actually, many of them had myocardial infarction, stroke, or chronic heart failure, around 42%. So they were high-risk patients, and in spite of this, they got improvement of most participants. One question here is that in this study, only 15% were taking SGL2 in the same time. And there was a debate here. If more patients are taking SGL2, would we have a better result or not? And still, this is debatable, because some recent study is showing that adding SGL2 to this group is not very beneficial, while others claim that it could be beneficial. Anyhow, in the FLOW study, the semaglutide arm was different from the placebo in the primary outcome. by, as you see here, 18.7 in the semaglutide arm versus 23.2 in the placebo arm. And the decrease in the proteinuria was again significant in the semaglutide by 0.6 versus the placebo by 0.8 when we followed those patients at week 104. The third important pillar here is the aldosterone antagonists. The aldosterone antagonists are present in medicine since more than a century. And we know that the aldosterone is present since the aldactone, for example, spironolactone is present since a long time. After that, we have the eplerenone present also after that. But this group, or this new group of selective aldosterone antagonists, has got an advantage of more albuminuria reduction and even more improvement in the GFR. This is one of the new molecules that still have a number. It got a name yet in the phase 2 clinical trial, and showing that out of 714 patients included in the study, the response rate alone was 50% versus 70% when added to empagliflozin. So it showed a 20% benefit of adding this group to the SGL2 inhibitor in this study. Again, we have another molecule, which is the fenrinone, giving a 10 milligram or 20 milligram. We have for this fenrinone two important studies, one called the Figaro DICG, and the other is called the Fidelio DICG. The Fidelio DICG shows that the composite endpoint to kidney failure is with 40% GFR decline over 4 weeks was good. And when they added the two studies to each other, and in this way they got a bigger number of patients, 5,734 patients, the key outcome was 57% kidney composite, and time to kidney failure sustained was 57%. So it was called in this pooled analysis. It was called the Fidelity study, and it was presented in the WCN in Argentina in April 2024. And this nephroprotective effect of the new MRAs is present in almost all the group, as you can see here, with patients with stage 4 chronic kidney disease. So you may even use it in some late stages. In this study, they included 890 participants. And this pushed many societies to include like the ADA and the KDIGO to published in October 2022 to put the sentence that a non-steroidal MRA with proven kidney and cardiovascular benefit is recommended for patients with type 2 diabetes, GFR more than 25, normal serum potassium, because we are afraid from some hyperkalemia with this agent, and albuminuria despite maximum tolerated dose of RAS inhibitors. Actually, we have many studies ongoing for this fenrinone. One of them is using them in type 1 diabetes, because up till now it is only used in type 2 diabetes, which is called the FINE-1. Another one is using them in children, because up till now they are using only in adults. But there is this FIONA study, including children with chronic kidney disease and proteinuria. One of them combining with empagliflozin, and FIND CKD also study. And in the last American Society of Nephrology, November 2024, there have been publication of the Fine Arts heart failure study, showing good evidence in cardiac patients, especially with heart failure. And in this group, also there was albuminuria decreased by 30%. Actually, could we use this drug, the RAS inhibitor, and got a role in patients with chronic kidney disease on dialysis? Actually, the Alchemist study showed that there was no much benefit in this, no improvement in primary cardiac criteria, only fewer hospitalization, and this has been done in 644 patients followed for 33 months by a big group, including Ziad Messi from France, showing that this aldosterone antagonist is not beneficial for chronic hemodialysis patient. It will not lead to much improvement. The fourth possible pillar on which there is much debate is bardoxolone. What is bardoxolone? It's an oral antioxidant inflammation modulator that has been present around 10 years ago in a big study called Bacon study and Beam study. And this Beacon study actually was done on type 2 diabetes with more than 2,000 patients in stage 4 chronic kidney disease. And the study unfortunately was terminated at 9 months because of excess mortality and hospitalization for heart failure. However, the Japanese group who were pro for this drug did not stop their activity. And they, in the last American Society of Nephrology, after 10 years, they are presenting the IAMA study, which is a randomized double-blind placebo-controlled phase 3, showing that bardoxolone given in diabetic kidney disease patient has not, as you see in their follow-up of 52 months, around 1 year, did not have significant difference regarding the cardiac affection, different from the old study 10 years ago. But I think we need some confirmation from other groups from than Japan. Number 5 here is the cause-directed for the delaying of the chronic kidney disease. We know that many patients in Africa will develop acute kidney injury because of infection, HIV, malaria, rhabdomyolysis, whether related to the weather or related to the trauma-related acute kidney injury because of the recent war conflicts in many parts of the world, including Libya, Yemen, etc., Gaza, etc. So all these causes will lead to acute kidney injury. Whether this acute kidney injury will progress to chronic kidney disease, we know that 30% of our patients with acute kidney injury will not become totally normal, and they will continue with chronic kidney disease. So prevention of acute kidney injury here is very important, and we should try to combat HIV, to combat malaria, to combat this rhabdomyolysis, and try to decrease the wars in the world. What about the traditional and complementary and alternative medicine? We know that Chinese herb nephropathy has been reported, and we know from this study, for example, coming from Durban in South Africa, that this induced nephrotoxicity by traditional and complementary and alternative medicine. This study has been on 226 patients with acute kidney injury between 1986 and 1988. The nephrotoxin was the major cause responsible for 20% of the cases, and the infection responsible for 30% of the cases. So again, the environment and the pollution, the heavy metals, the mycotoxin, the ochratoxins, all these share in the causes of acute kidney injury in Africa, in which 30% will progress definitely to chronic kidney disease. So preventing these factors will delay the progression of chronic kidney disease. Lastly, I will be speaking about the gene-directed therapy. We know that if we know the specific gene responsible, and I will give here the example of APOL1, which you can see it in the bottom of the table. APOL1 gene is important for APOL1 associated kidney disease, and nowadays there are some oral anti-APOL1 that is tried in the world to decrease the progression of FSGS, and could be in the future one of the way of decreasing the progression of FSGS in APOL1 patients and delay the progression of chronic kidney disease. But other examples include, if we know, for example, in Fabry disease, the gene responsible, and you give alpha-galactosidase enzyme replacement, if you know that in primary hyperoxaluria and you start to give the new RNA therapies, the serans, all these could delay the progression of chronic kidney disease and prevent these patients from going to dialysis or transplantation. I hope by this summary, I gave you an idea about different way, whether the current management, including the good evidence, the moderate evidence, and the insufficient evidence in reduction of progression, and the future management. Actually, they are not future, they are present management to reduce the progression, including the SGL2, the flozins, the SGLP1, the aldosterone antagonist, the phenrinone, the bardoxolone, and the course directed by combating the infection and the toxins, and the gene-directed therapy, like attacking, for example, the APOL1 or the oxalosis, or etc. Thank you for your attention.
Thank you, Prof. Hany, for that eloquent presentation, fairly comprehensive in such a short time. You had to go through quite a lot, and it's fairly informative. I just have one or two questions, and then I think we'll go to the chat box and see if there is more questions.
Yes.
So from my side, basically prevention or progression for patients with CKD, as you said, you know, the current treatment and the future treatment is actually also current. So it's important that we make sure that we do basically the lifestyle modification, the blood pressure control, the sugar control, everything more or less should be a target. And then despite that, if patients are then not responding, that's when we can add, you know, these other medications that you've mentioned, the phenterone, GLP-1, and flozins. The only one problem that we have, especially in developing countries, is the cost of these medications. And this is something that kind of is Achilles' heel. I know that there are generics for flozins, but the GLP-1s and the aldosterone antagonists, we still are waiting for them. And I think this is something that hopefully in due course will also come into generics, and the cost of the drugs will be less. So my question to you, Prof, is there are certain precautions that one needs to take, especially prescribing these medications, the flozins or the GLP-1s. Like for example, with the flozins, it is recommended that patients should be counseled on the amount of water that they drink, given that the flozins tend to cause osmotic diuresis because of the glucose reabsorption. So it's important to counsel them to make sure that they are replacing that fluid to avoid dehydration, because then that would worsen that. And then the other thing also is, I think it's important for the audience, and you can comment on this, Prof, is that it's important for the patient to be on baseline medication like adequate RAS blockade before you add, like say SGLT2 or GLP-1, because it's an additional therapy rather than, you know, starting off. And then finally, with regards to the creatinine, the GFR, there will always be an initial drop in the GFR, which then will come and kind of taper down later on. So if you do see a drop in GFR, should you be concerned about that, or should you continue with the treatment?
Thank you very much for these very important remarks and questions. I will start by the prescription of SGL2. It's important, of course, to keep the patient well hydrated, to avoid and to be sure that the patient also will not have a sort of urinary tract infection, especially in females, and to follow that the patient is not taking at the same time much medication which leads to more diuresis or more dehydration. So I think these are important, and up till now it is advised to whenever you are prescribing these patients to follow the GFR, and as you told, if there is a sort of temporary deterioration, in the first weeks, maybe 3 to 4 weeks, we can continue after, because the mechanism of action will lead maybe to some slight rise of creatinine in the first weeks, but the long-term benefit will continue after that to be beneficial. This is regarding the SGL2. Regarding the second comment, I think it is not very wise to start without a base of ACE and ARB. ACE and ARB are now present in the market for more than 40 years, and they constitute the backbone of the management, as I'm putting them in the good quality of evidence good. So the RAS blockade is the first thing to start with. And then you start to add one by one of these agents. It is not advisable to add all of them in the same time. You start, for example, by the patient is on good RAS blockade, and then you add SGL2 or you add GLP-1 and so on. Because if you give all of them in the same time, you may risk to have a significant drop in the GFR, and also you may have sometimes side effects of these combinations. Although some of them could be combined because there is a reciprocal effect on the potassium, for example. For example, if you are giving the phenrinone, the aldosterone antagonist, which lead to a little bit higher potassium, with the SGL2, which lead to a little bit lower potassium, this could be a good complementary effect. But in general, spacing by 2 to 3 weeks between each of these agents before addition is very advisable. Regarding the generics, I think now the generic for phenrinone is available in some countries, including Egypt. And since long time, the generic for SGL2 is present. Up till now, the GLP-1 generic is not available, but I think it will come in the short coming months.
Thank you, Prof. There are quite a few questions, so I'll try and get to all of them with the time that we have. So there's one question from Louis. He says, withholding these agents in acutely ill patients and monitoring. I believe that if the patient is acutely ill, the question is, should we withhold these treatments and then monitor, or should we continue with the treatment?
Of course, acutely ill, you mean the patient, for example, has infections or is severely dehydrated?
Perhaps, yeah.
Yeah, yes, of course, because these agents will not, this is a chronic treatment. I mean, a long-term benefit to reduce the progression. But if we use them in the acute event, it may not be of benefit, or even it may be injurious if we use them in improper way. For example, the aldosterone antagonists will lead to a sort of diuresis, for example. And if the patient is already dehydrated, so it will not be good to give him more diuretics, leading to deterioration of his hydration status.
Thank you, Prof. There's another question here that says that if I start RAS blocker as treatment of hypertension in normal creatinine level, how can we be cautious about rising kidney function? And in patients with chronic kidney disease, what is the cutoff point for serum creatinine or GFR to start ACE inhibitors or ARBs?
Thank you. This is a very important question. And actually, this has been a long debate between nephrologists and cardiologists. You know, cardiologists are fond of continuing the RAS blockade till late degrees because of their beneficial effect on the heart. And nephrologists, when they start to see that the GFR is declining, they stop it. And I think the British study of Stop ACE actually reassured the nephrologists that we can continue. We can continue with this drug with close observation. If you don't have a deterioration of more than 25% of the baseline GFR, you can advise the patient to continue. But if you have 40% deterioration, I think it is advisable to stop and to shift to another agent.
Right. Thank you, Prof. We've got a question from Dr. Amar Swali, who is also a nephrologist working with Shri Hindu Mandal in Dar es Salaam. He is asking, how can regional differences in socioeconomic status and healthcare infrastructure in Africa be integrated into individualized models for early detection and management of chronic kidney disease, considering the rise of non-communicable diseases?
Thank you for the question. Of course, it's very important to try to make a sort of prevention of this non-communicable disease that is not now only present in the developed countries, but also in the developing countries. As I show you in the first slide, the percentage of hypertension in Africa is even higher than United States and Europe. And according to the diabetes studies also, diabetes is increasing in our region more than in other parts of the world. So non-communicable disease, specifically hypertension and diabetes, are increasing. And so we don't have only chronic kidney disease because of infection, toxins, etc., and glomerular disease like before, but also the non-communicable are increasing. So prevention, and then when I speak about physical exercise, about diet, about protein restriction, about salt restriction, these are the ways to delay getting a good weight parameters, avoiding obesity, for example. All these factors will delay the non-communicable diseases and indirectly will lead to reducing the progression of chronic kidney disease.
Thank you, Prof. So we've got another question from Dr. Huda, who is also a nephrologist in the northern part of Tanzania. She is asking, with regards to alkali use, in my experience, most of my patients are getting GI side effects with sodium bicarbonate. Yeah. At which CKD stage you advise to start it? And if they get side effects, should we just stop or adjust the dose? Any alternative way to alkalinize blood apart from sodium bicarbonate?
Actually, there was one study showing that the Mediterranean diet, I mean, the based on vegetable and fruits, has got some alkali from the food itself. So I think this could be a reasonable alternative. Actually, we put our patient on such diets unless they have severe hyperkalemia, rich in vegetables and fruits, and this is will alkalinize, will give enough alkalinization for those patients who are intolerant to bicarbonate. And the dose could not be very high doses because you want to just reach the level of around 20. We don't, it's not very, and this could be achievable by just giving, for example, 0.5 gram twice per day, not more. I don't think this small dose will lead to severe GIT irritation.
Right, thank you. We've got another question from Prof. Naika from South Africa. While standard therapy, basically lifestyle measures, RAS blockade are the cornerstone of therapy, at what stage should SGLT2 inhibitors and GLP agonists be initiated?
Thank you very much, Professor Naika, and I'm very happy that you are attending with us. I think they are trying to decrease the GFR cutoff for these drugs. They started to telling that at the start they are telling we don't give it if the patient is GFR less than 30, then decreased it to 25, and then they are telling if the patient started it before he is 25, you can continue him even if he less than 25, become, for example, 22 or 20, you can continue if he started the drug before he got this deterioration. And I think this is, of course, a little bit individualized depending on the response of each patient. So if you find a patient in which there is marked deterioration of the GFR after the use of these drugs, we can stop it and shift it to another patient.
Thank you, Prof. I think the answer to this question is obvious, but I'm just going to ask it anyway. What's your practice around recurrent UTIs and vaginal candidiasis, to stop or not to stop? I think this is for the SGLT2s. If somebody gets recurrent UTIs or candidiasis.
I think it's wise to stop.
Right. Okay. Another question comes through and this is something that I always also kind of advise my patients. So there is the probiotics, Prof. There is a suggestion that probiotics introduction in patients with early stage CKD, use of probiotics tends to reduce the progression, or as you mentioned, the alpha keto analogs.
Yeah.
So the evidence is there, but it's strictly in clinical trials. I mean, pragmatically in real world, maybe your experience, have you used this, or do you have any answer to this? It should be something that we should prescribe to our patients, especially
Yes.
because of the cost of the drugs, that they are pretty expensive and majority of the patients cannot really, afford this.
I think the evidence that the probiotic and the prebiotics are beneficial is increasing in different parts of medicine, the GIT and the nephrology, and in many parts. So many of these actually are food additives, for example, the yogurt, etc. So giving or advising to have these, I think, and of course there are now drugs containing these agents. There is no much evidence, there is no much solid evidence. It will be included here under the insufficient quality of evidence that I am putting here, but it could be tried. Of course, there is no harm from giving them.
Thank you. Another question from Dr. Amar. He says, given the current gaps in epidemiological data on CKD in Africa, how can improved data collection methods such as mobile health platforms and community-based screening be improved in understanding CKD progression rates in African populations?
Thank you very much for this very important question. And I think our way in AFRAN now is to try to encourage each country to make its own registry. And we have here the very good example of the South African registry by Professor Sarala and Professor Razin, and other examples from Egypt and from other parts of the Africa. So we encourage every country, every nephrology community to try to make its own registry. This is the way, of course. But as you are telling, having the mobiles now widely spread among people will help to follow our patients. For example, if we are speaking about a sort of peritoneal dialysis in the home dialysis, and follow up with the mobile, with the center in which is giving the fluids and giving the care. They can get and communicate with their physician through the mobile. Even remote consultation, especially it was very prominent in the era of COVID. So the mobile will give us a way, of course, to track the different patients and get better statistics. This is an important way, but I encourage every nephrology society in Africa to have its own registry. In this way, we can publish, like the United Kingdom or the United States renal data system. We can publish our data also and say what is the real problem in Africa in solid numbers.
Thank you, Prof. We have a few more questions coming in. Clearly, this is a very important topic. So if you have some time, we can continue with a few.
I'm all yours.
Thank you, Prof. This is much appreciated. So we've got another question that asks, would you recommend using SGLT2 inhibitors in post-transplant diabetic patients?
There have been a few studies on that issue. and I think there is no much evidence, but the preliminary data are encouraging.
Okay.
But there are some studies of using SGL2 after transplantation.
Right. Obviously, the precautions would be the same as patients with CKD.
Yes.
So yeah. All right. There's another interesting question that is asking, would you still prefer introducing ARBs before SGLT2 inhibitors in CKD without albuminuria?
Definitely for controlling the blood pressure. Yes.
Yes.
Yes. If the patient is hypertensive, here the ARBs will be a very good starting point. SGL2 will give protection, but they will not control the blood pressure in the same way.
Yeah. Okay. Another question is, what is the trade name of finerenone in Egypt, please?
The generic?
Yeah.
Okay. I will send it to you. I don't remember it, but I will send it to you. Yes. Okay.
Okay. And then we'll send it to the person that asked.
I will send it to you by on the WhatsApp, Dr.
WhatsApp. Okay. Thank you. There's another question about how often should we check CKD progression? And then second question is, any benefit of SGLT2 inhibitors in non-diabetic patient initiating dialysis? Does SGLT2 inhibitors have any role in sodium regulation in these patients?
So the first is SGLT2 in patients on dialysis.
Yes.
The evidence will be not probably renal. It will be cardiac benefit. Because now there is some evidence of cardiac benefit of these agents, and we know that the first cause of mortality in our dialysis patient is cardiac mortality. So it will be beneficial in that sense, but I don't think it will have any effect on the renal profile for them.
Correct. You need to have kidney function for the drug to be beneficial.
Yeah, and many of them are already anuric or they don't have much uric.
Yes. The other question that the same person asked was, how often should we check for CKD progression?
Of course, as in the early stages, let's say every 3 months, and when you progress, for example, to CKD stage 3 to 4, I think you need every 4 to 6 weeks follow up. You cannot wait for a long time, especially if the patient is taking some drugs which may cause hyperkalemia. Yes. Especially the ACE and the aldosterone antagonist. All these patients may have hyperkalemia. So the shorter the duration of follow-up, the better.
Yeah. And I think also patients who are at high risk of developing CKD, patients with diabetes and hypertension, this should also be screened.
At more frequent rate, yes.
Yeah. Okay, Dr. Amar has another question. He is asking about the Mediterranean diet. This is recommended by KDIGO in 2024.
Yeah.
How do we remodel this in the African diet that varies in regionality throughout Africa?
It is called Mediterranean, but it is only vegetables and fruits. So it is not for the Mediterranean area. It could be, of course, for all Africa. I mean, in Africa we have much agriculture, and salads and all the items of salad and all the fruits, the different fruits could be used. But beware of hyperkalemia. This is the point that I'm always telling my patients when I start on the Mediterranean, because they may eat much bananas, for example, or much oranges, and this agent, if they are borderline hyperkalemic, it could be a little bit dangerous for those patients, especially in the late stages of CKD.
Right. One or two more questions, Prof. We have got a question from Dr. Ntarindwa, who is a nephrologist in Rwanda. He's asking, informative and relevant to our situation in the third world, can you comment on the effectiveness of V2 receptor blockers, tolvaptan, in slowing CKD progression in autosomal dominant polycystic kidney disease?
Yeah, thank you very much. This is an important question. Also, as you know, polycystic kidney disease has been excluded from the studies that I mentioned about the different agents that I mentioned. All of the polycystic are put away. In the polycystic, there have been two eras in the management. The first era was very encouraging the use of tolvaptan for every patient. And this resulted actually in increase in the liver enzymes and some toxicities that led many societies to discourage this behavior, and they stopped. And recently, there has been some guidelines, especially from Mayo Clinic. You may go for Mayo Clinic guidelines for use of tolvaptan and in polycystic kidney disease. Try to visit it. You will find that there are some specific cases of polycystic in which you may use the tolvaptan. Usually, it will be in the range of CKD stage 3, and with big cysts, and you should make how we call close follow-up of your patients and be sure that the patient is not dehydrated. So they are putting many criteria for those patients who will be candidate for the tolvaptan. So now they don't absolutely say that we don't use it, but we use it in some specific group of polycystic.
Question, and then we will end this. I think the last question was by Dr. Tahani. She's also a nephrologist in Dar es Salaam, and she asked about something about gum arabic and CKD progression. Do you know if there is any ruling about that?
Yes. Actually, we have some studies that has been in Germany from the use of gum arabic many years ago. And then Dr. Salma from Sudan also did and published some study of the use of gum arabic, and the benefit was decrease in the urea and some decrease in the potassium. Actually, I myself and my late professor Rashad Barsoum, we concluded a study in our Cairo University about gum arabic. And also we got similar result in some decrease in the urea and potassium. But of course, we tell the patient if they wanted to have a food additive, gum arabic is a good option. And also honey also is a good option in decrease in the urea. But they will not replace the treatment, because the problem when you prescribe some additives like this for patients, they don't take the medication and they will tell, okay, we'll take these and we'll not take the tablets. So add on, it's okay. Agree on gum arabic benefit and on honey benefit.
Thank you. Thank you very much, Prof. And thank you very much for your time. And as mentioned earlier, for your comprehensive, eloquent presentation. Clearly, we had close to about 150 participants on the chat, if not more, and it was fairly engaging with a lot of questions coming in. Some of them I had to filter them down and combine them. So thank you very much for your presentation, your attendance, and we hope to see you again in the near future. If you have anything on your mind, Prof, you're more than welcome to just drop me a WhatsApp message and we will accommodate you as needed.
Thank you very, very much. It was very, very nice to be with you, and hope we meet in person soon. Thank you.
Soon. Thank you so much. Thank you.
Thank you.
Have a nice evening.
Bye.
Thanks. Bye.
Bye.